I thought I would just ground the presentation in a little bit about our Ontario Health team to start with. We were one of the first OHTs in the province to be approved, and that was in November of 2019. And our attributed population is actually quite large, one of the larger Ontario Health teams at about 620 to about 675,000 residents. And we span a geography of Hamilton, Haldimand, and a portion of Niagara. It's also important that we recognize our OHT supports individuals from two neighboring reserves, Mississaugas of the Credit and Six Nations of the Grand River. So considerations for on-reserve and urban Indigenous care are very important to our OHT. I won't get into detail about our population, but I will say that we do have a mix of rural and urban communities, which poses its own, health and social challenges as we plan integrated care together. We have extremely high areas of material deprivation. Hamilton is one of the highest concentrations of urban poverty within Canada. We know that our senior population in all of our regions that our OHT is attributed to is growing. And mental health and addictions continues to be a significant local health burden. And these concerns have really only been exacerbated by the pandemic. A little bit about our journey to date. As I said, we were approved as a OHT in 2019. In late 2019. At that time, we submitted an application to be a Hamilton, Ontario Health team, just concentrated on Hamilton alone. And we did get approved as a Hamilton team. The pandemic sits there in around March 2020, where we actually utilized kind of our OHT structure and governance as it was to come together under an integrated COVID response. In February, we learned that we would actually be integrated with two other regions. So that posed some interesting challenges as we were thinking we would move along as Hamilton proper. We actually brought in another region, Haldimand. We did a huge rebranding to reflect our full attributed population. And I will talk about the journey that we actually became the first incorporated Ontario Health team in the province in December of 2021. So, the most common question is why did we decide to do this? Why did we move to a not-for-profit incorporation at a time where consensus decision-making across the province was the model that was used by Ontario Health teams? And, much to what Mirella was saying, this was all about relationships. We decided that our Ontario Health team would really be that glue to bring in organizations to think about the well-being of our entire population. We already had extremely mature partnerships in the region. I will say from decades of working together on integrated initiatives. So I really felt that, we really felt as an OHT, we had the foundation to start looking at a more mature governance model and not have it as loose as at the time the ministry was announcing. We wanted to move away from specifically looking at organizational mandates to looking at the health of the whole entire community. And we knew that we would do that with a more robust and accountable model. So we felt that the not-for-profit corporation model provided more structure and accountability for us to start that work. We also wanted autonomy in operations, potential to receive funds, procure, hire into an organization, potentially one day become a health information custodian and deliver services. And then we knew that incorporation at a board of directors model was a model that organizations were already quite familiar with. So this was really quite new because we were bringing together multiple organizations to think about how we were going to be, a shared ecosystem moving forward. I will also say that our Ontario Health team has a wide array of partners, from healthcare partners to social care partners. So we had several inputs into our governance work, and I'll highlight this at the end that this was a huge undertaking that we were doing, throughout the pandemic. We first started with a smaller consultation with Ernst & Young, where we started to explore what were the models that would make sense. No one's ever really done this before in Ontario in this way. So was incorporation going to make sense? A charity organization, a venture organization, or, just actually going with the kind of collaborative decision-making process the ministry had set out. So we did a few months of actually just exploring the potential options. The second main input was that we decided to base our Ontario Health team work off of health equity. We knew that people in our OHT population suffered at times a 13 to 15-year life expectancy difference based on where they lived. We knew that we were seeing poor outcomes when it comes to equitable health access. We knew that certain populations were at risk. So we really wanted to have health equity at the very start of all of our governance journey. And in 2021, we spent most of that summer doing extremely large, small, multiple kind of partner consultations to understand what were the pain points from our network organizations. How were they feeling? Building up that trust was really important to us. So like I said, our journey really began with health equity. We decided to do a 6-month kind of consultation with our community with the mandate of developing a framework and action plan in 3 specific areas for our OHT. Number 1 was, how do we deliver care to patients from a lens of health equity? Number 2, how were the operations of my own staff and the project management going to operate from a lens of health equity? And then really, we knew that we were going to be undertaking a governance redo. How does health equity become part of the DNA and governance structure of our OHT? So in June of 2021, we completed a really comprehensive health equity report that included 24 key recommendations on how we were going to move an equitable health agenda forward, including what would a board of directors look like? How do we include diverse voices? How do we represent marginalized populations that we know are suffering from inequitable health outcomes in our city? This report was completed by a council. It included 7 population-specific focus groups, 25 key informant interviews. We did extensive review of already developed local and provincial reports, and we also considered the applicability of the Ontario Health Equity Framework. So then in the summer of 2021, our OHT staff led several partner consultations. Again, we wanted buy-in from our partners. We weren't going to go down a venture that everyone was really adverse to. What were the pain points from people that were going to be part of this model? Did they see value? What could we help with? So we led those partner consultations over the summer, and we reported back on the findings of both reports, the Ernst & Young, where we went over several, governance options, and the health equity report. We allowed partners to ruminate and understand the model and what the implications were. Our biggest questions through that time were, how will this affect my own funding and my own board? But at the end of it, I will say there was less fear about coming together as a not-for-profit corporation than we actually expected. And because of the moment in time, we weren't asking organizations to give up their funding and cross-integrate and close down their shop and become part of a bigger entity. We're really starting the work by understanding how we're going to be this shared model moving forward. The unique thing right now about how healthcare is still structured under the OHT model is that the accountability and funding agreements right now still lie with the Ministry of Health. There are small testaments of change of how we've dealt with funding and decisions since then. But right now, that accountability is still laying there. So it kind of gives us a little bit of a runway to test out working together and continue to build in that trust and relationship. Who's going to be an incorporated member of our OHT? You have to be an incorporated entity already. You have to be in existence for at least 5 years, ability to demonstrate good financial standing. You're able to offer services that contribute to our care pathways for those of people living within our catchment area. You must declare the sector of membership for which you are applying, which I'll get to in a few slides. And then we're in the midst of developing a membership agreement. What does it mean? And what does the defining factors of being part of our incorporated work mean? So how are decisions going to be made after we formed our incorporation? There is going to be 18 board seats. 15 directors are nominated by class or stakeholder councils, which I'll show in the next slide. We made sure that there was 3 independent directors to ensure that we're filling out our skills and competencies. And that was a big recommendation from our health equity report. And really, the directors are serving on behalf of the entire health of the community and not their organizations. This is just a snapshot of kind of our current board structure. You'll see that our project management office and my office reports into the board, but that we have 4 formal stakeholder councils. And really, these councils, they undertake planning and operations of our OHT, but they're also important because these are non-incorporated members of our OHT that form part of these stakeholder councils, but you'll see in the next slide have a seat at our board. It's a little bit complicated because we didn't want to have, every individual physician signing up to be part of our incorporation, but we knew that primary care was an important seat. So primary care has formed its own council, and all of these councils feed directly into our board. Underneath that are several working groups. This is where a lot of the decision-making is actually being brought forward to the board. I'll say that within those working groups, there is, there's no delineation between whether or not you are a large organization or a small one. We work with anybody that is part of our integrated care models and a part of our populations of concern. And that ranges from small charity organizations, health providers, social providers, municipal providers. This is the structure of our board. And you'll see here in the green, those are the stakeholder councils. And those were also decided because they were important levers for our success. I see in the chat, why does Haldimand have its own council? Because we brought in Haldimand post after us being approved, because they have their own unique local nuances, we wanted to ensure that there was a direct connection between that group and the formal board of directors. The board seats on the sectors were chosen based on our priority populations, based on our health equity report, and based on the fact that we wanted to ensure that there were empty seats to round out any diversity, any concerns about, changes in direction on Ontario health teams. We want to be able to be nimble and open to responding. As of right now, we are currently building up to this 18-member board. So when I think about, key messages about our learnings about actually doing this model, individuals are not members, but they are part of those stakeholder councils and all of the working groups as part of our OHT. I do want to reiterate that any organization can be part of integrated care working groups under our OHT. And I feel like this is very important for true integrated care. We have seen enormous success by partnering with organizations that have never been part of the health space before. This structure is taking time to mature. You'll see it's been a few years journey, and because we're doing it for the first time, even just figuring out the legal aspects of what this means, bringing on the trust of the partners, and even just communicating the model to everyone in the area, has been, a lot of time and effort put in. Continuing on the key learnings, it's resource intensive, not only in the development of a model like this, but in the implementation. We're still working through implementation. And for those familiar with the Ontario Health Team model in the province, they're not funded with a whole bunch of back office staff. At the heart of this, I have 8 full-time staff that get up and think about the Ontario Health Team every single day. So it's more complicated with the more partners involved, but it really does take a lot of dedication to moving this forward. I'll say that along the way, though, even though it's taken time, it really allowed us to have opportunities for dialogue and decisions in a new way. Nobody around the table has really formed an incorporation like this before. So we know it's not perfect. We know that it's going to take time, but already I can say from the board level, we're thinking in a more shared and collaborative way, less about those individual organizational mandates and more about the health of our entire shared population. And organizations are coming to the table about, well, what can I lend to the population health model? It's built a lot of trust. I'll say that, going back to, I feel the OHT model now is seen as the glue of the community, where our community and social partners are coming to say, here, I have a shared problem that needs cross-sectoral help. This is where we're going to go to. It is definitely a work in progress. It takes money and it takes staff time. We are still implementing that structure, especially since the staff team is so lean. But we were really, happy and surprised to hear that the Ministry of Health has chosen this model for all OHTs to move forward with in the future. I think that's it for me. I just leave the last slide with our connections. Please stay connected and happy to answer any questions.